Hello again. So our topic for today is immunologic tolerance and autoimmunity, and this is lesson 7 of our module in MLS 021 or immunoserology. Immunologic tolerance refers to the situation in which, under certain conditions or circumstances, a foreign antigen fails to elicit the formation of antibody in recipient. So the term immunologic non-responsive and immune paralysis are somehow synonymous with immunologic tolerance. In 1941, Burnett and Fenner postulated that animals would be tolerant towards antigen encountered during embryonic life. This was considered the basis whereby the antigens indigenous to the body, like the self-antigens, were recognized and therefore did not provoke immune responses, whereas foreign antigens, like the non-self, did. Studies of immune tolerance stem from the work of Owen in 1945, who made the observation that dizygotic twin cattle, or the non-identical, uh, which share the same placental circulation and whose circulations were thereby linked, known as chimerism, progressed through life with appreciable numbers of each other's red cells in their blood. Conversely, if they had not shared the same circulation, red cells from one twin injected into the other rapidly provoked an immune response. On the other hand, the hypothesis by Burnett and Fenner in 1941 was put to test by Billingham and co-workers in 1953, who injected embryonic mice with adult cells and showed that after birth, the infant mice were tolerant towards skin from the same adult donors. Tolerance can also be induced using soluble antigens. For example, rabbits injected at birth with bovine serum albumin failed to make antibodies on later challenge with this protein. Other immunogens that induce state of tolerance includes bacteria and tissue cells. This was according to Barrett in 1988. Now, it is realized that tolerance can be induced in the adult as well as in the neonates. T cells are involved in tolerance at low antigen levels, whereas both B and T cells are made unresponsive at high antigen dose. The mechanism of immune tolerance are the following: chimerism, fetal exposure to antigen, and B-cell tolerance. B-cell tolerance can be induced by 1. Clonal abortion, 2. Clonal exhaustion, 3. Functional deletion, and 4. Antibody-forming cell blockage. Now, for clonal abortion, this occurs when an immature B cell is exposed to a low concentration of antigen and the maturation of that B cell is released so that it may not respond to that antigen on subsequent exposure, while clonal exhaustion, on the other hand, occurs when a B cell is repeatedly exposed to T-independent antigens. All mature B cells expressing the receptor for this antigen are already antibody-producing cells. Therefore, no additional antigen binding and antibody production can occur. Uh, on the other hand, the functional deletion occurs when T helper cells are not present to help T-dependent antigens, thereby not allowing B cells to mature into antibody-producing cells. This type of tolerance occurs in cases of high antigen dose, where there are too few B cells to respond to such a dose. And lastly, when we talk about antibody-forming cell blockage, this mechanism has a low ability to induce tolerance, and it occurs when antigen binds to all receptors and thereby inhibits immunoglobulin secretion. T-cell tolerance, on the other hand, can be induced by the following. First, we have clonal abortion. Second, functional deletion. and third, T-cell suppression. Now, for clonal abortion, as with immature B cells, immature T cells may also be clonally aborted. This is when the immature T cell is exposed to low antigen concentration and its maturation is arrested so that the T cell may not respond to that antigen on subsequent exposure. While functional deletion, on the other hand, occurs when one T cell subset becomes tolerant to an antigenic determinant and fails to stimulate a functional B cell to produce antibody. And for T cell suppression, this occurs when suppressor T cells actively suppress other T cell subset or B cells. So, B and T cell tolerance differ with respect to the time taken to become tolerant of, like for example, T-dependent antigens may tolerate T cell found in the spleen and thymus within hours of challenge, but requires up to 4 days to tolerate adult splenic B cells. Another thing, the required dosage is also important, like B-cell tolerance requires a considerably higher level of antigen than that required for T-cell tolerance. And lastly, the duration of the state of tolerance, which is dependent on the mechanism by which tolerance was induced and to some extent on the persistence of the antigen. So the ability of the body not to respond to autologous antigens is known as self-tolerance, while some B cells are normally present in an individual that recognize autologous antigens. They are inactive because of the lack of antigen recognition by T helper cells. This was actually could be an example of functional deletion. Autoimmunity is a condition in which an immune response is stimulated by self-antigen, and the resulting antibodies then react with these self-antigens in the same way as they do with foreign antigens, which may result in autoimmune disease. Well, as previously stated, under normal conditions and circumstances, an individual does not produce antibodies to antigens regarded as self. In certain cases, however, the mechanism that prevents their formation may break down, giving rise to the production of self-antibodies, or we call it autoantibodies, which are directed against the individual's own tissues. Autoimmune disease or disorders, on the other hand, develops when evident immunoglobulins or autoantibodies or cytotoxic T cells display specificity for self-antigens or autoantigens and contribute to the pathogenesis of the disorder. These are conditions in which the presence of an autoantibody or autoactive cells cause damage to organ or tissues. Um, these are also conditions in which damage to organs or tissues result from the presence of autoantibody or autoreactive cells. Such disease affects 5 to 7% of the population and are thought to be caused by the loss of breakdown of self-tolerance. In early 1900s, Ehrlich describes this phenomenon as horror autotoxicos, literally meaning fear of self-poisoning. Thus, it was recognized early on that under normal circumstances, the immune response was held in check so that self-antigens were not destroyed. There are theoretically three circumstances under which autoantibodies are produced. First, if the antigenicity of tissue proteins is altered due to degenerative lesions such as following necrosis of tissues, such as in skin burns, or the attachment of haptens, in which case the antibodies are directed against the hapten rather than against the normal tissue proteins. Second, if a tissue antigen is automatically isolated from immunologically competent cells and therefore not recognized as self, The release of these antigen into the tissues following injury or disease results in the formation of autoantibodies. And lastly, if a self-protein is no longer recognized due to altered reactivity of the immune mechanisms, this last condition is known to occur in cases of lymphocytic leukemia. In cases such as this, autohemolysins are sometimes produced, giving rise to a hemolytic anemia. Now, autoantibodies may be immunoglobulin or cellular. The immunoglobulin might be of any class and may be organ-specific, example, directed against a determinant present in one organ, or non-organ specific, like directed against DNA, mitochondria, and immunoglobulin determinants. Well, for the pathogenesis of autoimmunity, there are general mechanisms of autoimmune reaction. First, defects in deletion, which is the negative selection of T or B cells or receptor editing in B cells. Second, we have defective numbers and functions of regulatory T lymphocytes, defective apoptosis of mature self-reactive lymphocytes, inadequate function of inhibitory receptors, and lastly, activation of APCs, which overcome regulatory mechanisms and result in excessive T cell activation. Now, for the factors influencing development of autoimmunity, it is divided into three. First, we have the genetic basis of autoimmunity, in which the inheritance of multiple genetic polymorphism in affected individuals contribute to their disease susceptibility, and these genes act with environmental factors to cause the disease. Second, we have MHC genes, which thought to have the strongest association among the genes that are associated with autoimmunity. Well, MHC products also seem to influence antigen recognition or non-recognition by determining the type of peptides that can be presented to the T cells. There is a close fit between an antigenic peptide and the groove of an individual MHC molecules. So, inheritance of a gene coding for a specific MHC molecule may make an individual more susceptible to a particular autoimmune disease. Second, we also have serologic typing of one HLA locus. Now, the strongest link found to date between certain HLA molecules and specific diseases is between HLA B27 and ankylosing spondylitis. Individuals who possess HLA-B27 have a 90 times greater chance of developing the disease than the normal population. Then we also have the role of infections in autoimmunity. Now, several other mechanisms are thought to contribute to autoimmunity. Release of sequestered antigens, molecular mimicry, and polyclonal B-cell activations. Antigens that are protected from encountering the circulation are not exposed to potentially reactive lymphocytes. Example of these are myelin basic protein, normally sequestered by the blood-brain barrier, and sperm. Well, for the development of exacerbation of autoimmunity, it can be associated with viral or bacterial bystanders, or we call it molecular mimicry. Molecular mimicry refers to the fact that many individual viral or bacterial agents contain antigens that closely resembles self-antigen. Now, exposure to such foreign antigens may trigger antibody production that in turn reacts with similar self-antigens. Example of these are poliovirus, WP2, and acetylcholine receptor, the measles virus, P3, and myelin basic protein, and we have papilloma virus, the E2, and insulin receptors. Well, further examples we will be discussing them as we go along with our discussions. Well, the last major factor is the polyclonal B cell activation. For B cell defects include the abnormal expression or function of key signaling molecules, dysregulation of cytokines, and changes in B cell development subsets. Well, another thing is the Another factor in autoimmunity, is the inflammation, which is possible secondary to infections. We have ischemic injury or trauma. Now, trauma to the tissue by means of an accident or infection may introduce such antigens to the general circulation. And in some autoimmune disease, hormonal influences will also play a role. So we have major factor that contributes to the development of autoimmunity. We have the genetic susceptibility, which has been discussed earlier, and the environmental triggers. So beside the factors mentioned previously, several other must be taken into account in the etiology of autoimmune disease. Some of these are defects in the immune system, the influence of hormones, as mentioned in the other factors previously, from the previous slide, and we have environmental conditions. Now, defects in natural killer cells in the secretion of cytokines, in apoptosis or killing of cells, and in complement components all may contribute to the loss of self-tolerance. We have hormones, especially estrogen, may also play a role because they are known to affect cytokine production and may influence T cells, either T helper 1 or Th2, which are more active in a particular response. So as mentioned earlier, autoimmune diseases are conditions in which damage to organs or tissues result from the presence of autoantibody or autoreactive cells. Such disease affects 5 to 7% of the population and are thought to be caused by the loss or breakdown of self-tolerance. Thus, as previously discussed, based on autoimmunity, there is not one cause but many contributing factors that are responsible for the pathological conditions found in autoimmune diseases. Further, autoimmune diseases can be classified as systemic or organ-specific. There is often a good bit of overlap between the two because some diseases that start out as organ-specific later affect other organs. One popular example of autoimmune disease is systemic lupus erythematosus, or we call it the SLE. So it represents the prototype of autoimmune diseases. Actually, it is a chronic systemic inflammatory disease marked by altering exacerbation and remission affecting 15 and 50 individuals out of 100,000 in the United States. This is based on statistics. The incidence of the disease has tripled over the last 4 years. Now, the peak age of onset is usually between 20 and 40 years of age. Women are much more likely than men to be stricken by this disease by a margin of approximately 10 to 1. It is also more common in African Americans and Hispanics than in whites. With earlier diagnosis and improved treatment, the 5-year survival rate has increased to greater than 90%. Now, the immune response is directed against a broad range of target antigens, as the typical patient has an average of 3 circulating autoantibodies. Now, it appears that there is an interplay between genetic susceptibility and environmental. As mentioned earlier, it appears that there is an interplay between genetic susceptibility and environmental factors. In fact, in whites, there is a strong association with um, with human leukocytes, antigens, the HLA, DR, and DQ, has been associated with inherited deficiencies of complement components, the C1q, C2, and C4, abnormalities of Fc gamma receptors on B cells, macrophages, dendritic cells, and neutrophils that binds immunoglobulin G and prevent excess immune reactions have been found as well. Well, for the environmental factors, exposure to ultraviolet light and certain medications and infectious agent plays an important role. Hormones such as estrogen containing contraceptives or hormones replacement therapy has been found to double the risk of developing lupus as well. Hormones plays an important role because they may influence the regulation of transcription of genes that are central to the SLE expression. In fact, the use of estrogen-containing contraceptives, as mentioned a while ago, or hormone replacement therapy has been found to double again the risk of developing lupus. Now, for the clinical signs and symptoms of SLE, well, clinical signs for SLE are extremely diverse and nonspecific symptoms, such as we have fatigue, weight loss, malaise, fever, and anorexia are often the first to appear. Joint involvement seems to be the most frequently reported manifestation because over 90% of patients with SLE are subject to arthritis or polyarthralgias. Typically, the arthritis is symmetric and involves the small joints of the hands, wrists, and knees. Well, after joint involvement, the next most common signs are skin manifestations. An erythematous rash may appear in any area of the body exposed to ultraviolet light. Less common but perhaps most dramatic is the appearance of the classic butterfly rash across the nose and cheeks. Well, this is what is responsible for the name lupus, which derived from the Latin term meaning wolf-like. This rash appears in only about 30 to 40% of all patients. Now, in discoid lupus, skin lesions have central atrophy and scarring. Other systemic effects of SLE. So, one half to two-thirds of all patients exhibits evidence of renal involvement at the same time. There are several types of lesions, but the most dangerous is the DPNG, or the diffuse proliferative glomerulonephritis, in which there is a cellular proliferation in at least 50% of the glomeruli. Now, 20% of individuals with DPNG will die or develop end-stage renal disease within 10 years of diagnosis. Other conditions may include deposition of immune complexes in the subendothelial tissues and thickening of the basement membrane. All of these can lead to renal failure and the most frequent cause of death in patients with SLE. Well, other systemic effects may include cardiac involvement with pericarditis, tachycardia, or ventricular enlargement, pruritus with chest pain, neuropsychiatric manifestations such as seizures, mild cognitive dysfunction, psychosis, or depression. Or we also have hematologic abnormalities such as anemia, leukopenia, thrombocytopenia, or lymphopenia. In order for a clinical diagnosis of lupus to be made, 4 or 11 4 out of 11, I mean specific criteria must be present. So we have the following: malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, serositis, renal disorders, neurological disorders, hematologic disorders, immunologic um, disorders, and presence of anti-nuclear antibodies. Now, within the category of immunologic disorders are your antibodies to double-stranded DNA, to Smith antigen, and to phospholipid. Well, the first clue in the mystery of lupus was the discovery of the LE cell in 1948 by Malcolm Graves. The LE cell is a neutrophil that has engulfed the antibody-coated nucleus of another neutrophil. This phenomenon, which mainly appears in vitro, occurs when cells are damaged and release nuclear materials. Then, 9 years after the LE cell was discovered, which was in 1957, the first anti-DNA antibody was identified. Now, it is known that SLE is associated with more than 25 autoantibodies. While the large number of possible autoantibodies reflects a generalized dysregulation of the immune system, there is an uncontrolled autoreactivity of T and B cells leading to the production of antibodies. Autoantibodies, I mean. This activity may be due to deficiency of regulatory T cells. Well, regulatory T cells, or we call it the TRIGs, play a crucial role in the maintenance of self-tolerance in peripheral lymphoid organs as they suppress T cell proliferation. Tregs in lupus seem to be more sensitive to apoptosis or programmed cell death. Well, in addition, altered Fc receptors for immunoglobulin G on B cell keep them from being switched off so they continue to produce antibody. Dysfunctional processing in the routine non-immunologic clearing of cellular debris may also be a key to the pathogenesis of SLE. Abnormal apoptosis of certain types of cells may occur, releasing excess amounts of cellular constituents such as DNA and RNA. Individuals who inherit certain HLA genes are most likely to respond to such self-antigens. No. Constant presence of antigenic materials triggers polyclonal activation of B cells, one of the main immunologic characteristics in lupus. There is an accompanying alterations in the function of both T helper 1 and T helper 2 cells, resulting in enhanced production of self-certain cytokines that contributes to upregulation of antibody production by B cells. Well, in particular, increased production of interleukin-10, which normally serves as immunosuppressive role, correlates with increased antibody production and with, with disease activity. While interleukin-10 appears to trigger an increase in antibodies directed against DNA and stimulate production of platelet activating factor. Once immune complexes are formed, they cannot be cleared as well from the circulation because of other possible deficiencies. These includes defects in complement receptors on phagocytic cells, defects in receptors for the Fc portion of immunoglobulins, or deficiencies of early complement components such as C1q, C2, or C4. The accumulation of immunoglobulin G to double-stranded DNA seems to be the most pathogenic because it forms complexes of an intermediate size that become deposited in the glomerular basement membrane. In addition, anti-DNA antibody may also react directly with proteins such as alpha-actin, which is found in the basement of membrane. This enhances activation of the complement cascade, which contributes to the kidney damage seen with this disease. Drug-induced SLE differs from more chronic form in that symptoms usually disappears once the drug is discontinued. Most common drugs implicated, we have prokinamide, hydralazine, chlorpromazine, isoniazid, quinidine, anticonvulsants such as methyldopa, and possible oral contraceptives. For the laboratory diagnosis of the SLE, we have the screening test. So when SLE is suspected, the first test typically done is the screening test for anti-nuclear antibodies, or ANA. Fluorescent anti-nuclear antibody, or the FANA testing, is the most widely used and accepted test because it detects a wide range of antibodies and is positive in about 95% of the patient with lupus. This is an extremely sensitive test and relatively easy to perform, but it has low diagnostic specificity because many of the antibodies are associated with other autoimmune diseases. Well, the picture below shows patterns of immunofluorescence staining for ANA. I got this from the link below, so if you would want to visit, you can click the link and browse through it. So, first of the pattern is we have the homogeneous, which is the first one. Then this one is the homogeneous here. Then the letter B, that is the speckled. Then we have the third one, the nuclear dots. The fourth one on the upper portion is the nucleolar. And the first one below is the pattern we call centromeres. Additionally, the following patterns of related antibodies can be recognized. So the second one below, we have the nuclear membranes. The third is cytoplasmic. And finally, negative and unspecific results, we have the last one, the low part, are recognized and selected in a different tab. So ANA are anti-nuclear antibodies and indirect immunofluorescence. Well, there are other assays for ANA, namely we have immunodiffusion, which used to determine the immunologic specificity of positive FANA test or the fluorescence anti-nuclear antibodies. We have the immunoblotting technique, which separates out antigens by means of polyacrylamide gel electrophoresis. We have the EIA, which used for detection of anti-double-stranded DNA, anti-histone antibodies, and anti-single-stranded A and anti-single-stranded B. Antiphospholipid antibodies is the fourth one, which have been found in up to 60% of patients with SLE. As with regards to the treatment of SLE, if fever or arthritis is the primary symptoms, well, a high dose of aspirin is highly recommended, or other anti-inflammatory drugs, which could also bring relief. For skin manifestations, anti-malarial drugs such as hydroxychloroquine or chloroquine or topical steroids is advised. For cases of acute fulminant lupus or lupus nephritis, or in any cases CNS involvement, systemic corticosteroids is advised to use. Other drugs such as cyclophosphamide, azathioprine, methotrexate, and chlorambucil is also advised. And a new approach for patients, whose symptoms cannot be controlled by other means involves autologous stem cell harvesting and remission after the patient undergoes intensive chemotherapy. Well, the result indicates that long-term remission may be possible using this method, the autologous stem cell harvesting. Overall, the present 5-year survival rate approaches 90%. Well, another example of systemic autoimmune disorder is the rheumatoid arthritis, or the RA. It affects approximately 1% of the population in the Western world. Women are 3 times as likely to be affected as men, and typically it strikes individuals between the age of 35 and 50, although it may occur at any age. Rheumatoid arthritis can be characterized as chronic, symmetric, and erosive arthritis of the peripheral joints that can also affect multiple organs such as the heart and the lungs. In addition to a declined functional ability, there is a reduced life expectancy as well. Progress of the disease varies because there may be spontaneous remission or an increasingly active disease in some individuals that rapidly progresses to joint deformity and disability. As in SLE, there appears to be an association of RA or rheumatoid arthritis with certain MHC class II genes. These genes code for the beta chain, one of the 2 chains that make up the HLA class II antigens. Now, the strongest association appears with certain DR4 alleles, and this occurs in 70% of patients with rheumatoid arthritis. All of the alleles involved appears to code for a similar amino acid sequence at position 67 to 74 in the beta chain. Now, this shared epitope on the HLA class II beta chain may act to facilitate antigen presentation to T helper cells and to B cells. Now, for the diagnosis of rheumatoid arthritis, it is based on the 1987 criteria established by the American College of Rheumatology. Key symptoms are morning stiffness around the joints lasting at least 1 hour, swelling of the soft tissue around 3 or more joints, and swelling of the proximal interphalangeal, metacarpophalangeal, or wrist joints, symmetric arthritis, subcutaneous nodules, a positive test for RA or rheumatoid factor or RF, and radiographic evidence of erosions in the joints of the hands, the wrist, or both. At least 4 of these must be present for 6 weeks or more for the diagnosis to be made. Now, typically the patient experiences nonspecific symptoms such as malaise, fatigue, fever, weight loss, and transient joint pain that begins in the small joints of the hands and feet. Morning stiffness and joint pain usually improve during the day. Joint involvement progresses to the larger joints in a symmetric fashion, often affecting the knees, the hips, elbow, shoulders, and cervical spine. The joint pain experience leads to muscle spasm, which, because of the consequent limitations of motion, result in permanent joint deformity. About 20% of patients have nodules over the bones. Nodules can also be found in the myocardium, pericardium, heart valve, pleural, lungs, spleen, and larynx. Other systemic symptoms may include anemia, formation of subcutaneous nodules, pericarditis, lymphadenopathy, splenomegaly, interstitial lung disease, or vasculitis. Felty syndrome is a combination of several of these symptoms. We have chronic rheumatoid arthritis coupled with neutropenia, splenomegaly, and possibly thrombocytopenia. Well, for many years, there has been a search for an infectious agent or agents that may be involved in the etiology of rheumatoid arthritis. Numerous agents, including mycoplasma, rubella, or possible triggering antigens. In fact, an increased titer of antibody to EBV and some other viruses have been found in patients with rheumatoid arthritis, but a causal relationship has not been established. Well, this picture represents the normal joint and the joints with rheumatoid arthritis. Now, if you happen to notice on the normal joints area, the synovial fluid is quite um, quite normal, while in cases of rheumatoid arthritis, the synovial fluid, uh, the swollen, inflamed synovial membrane is very much evident, and there is a bone erosion as well. Now, that makes the joint inflamed and somehow painful for the person having the disease. For the immunologic findings of rheumatoid arthritis, well, the earliest lesion in rheumatoid joints show an increase in cell lining, the synovium, and an infiltration of mononuclear cells, mostly CD4 positive T cell lymphocytes. The CD8 positive T cells are scattered throughout, as are B cells and antibody producing plasma cells. Macrophages and neutrophils are attracted to the area, and this results in the formation of an organized mass of cells called a pannus, which grows into the joint space and invades the cartilage. While the balance between inflammatory and anti-inflammatory cytokines appears to be tipped towards continual inflammation, pro-inflammatory cytokines found in synovial fluid that contributes to inflammation are interleukin-1, interleukin-6, interleukin-8, interleukin-15, interleukin-18, and tumor necrosis factor alpha, or the TNF-alpha. While TNF-alpha plays a key role in the inflammatory process by inducing continual secretion of interleukin-1, 6, and 8, and in addition, the TNF-alpha facilitates the transport of white blood cells to the affected areas. Collagenase and other tissue-degrading enzymes are also released from synoviocytes and chondrocytes that line the joint cavity. The end result is destruction of connective tissue, cartilage, and bone. Well, it is not known what role antibodies play in initiation of the inflammatory response. Approximately 75% of patients with rheumatoid arthritis have an antibody that has been called rheumatoid factor. Well, it is often the IgM class and is directed against the Fc portion of immunoglobulin G. However, this antibody is not specific for RA, as it is found in 5% of healthy individuals and in 10 to 20% of those over the age of 65. Well, in RA, IgM antibodies combined with IgG, and these immune complexes become deposited in the joints, resulting in the type 3, or we call it immune complex hypersensitivity reaction. The complement component C1 binds to the immune complexes, activating the classical complement cascade. Now, during this process, C3A and C5A are generated, which act as chemotactic factors for neutrophils and macrophages. The continual process of macrophages leads to the chronic inflammation usually absorbed, which damages the synovium itself. Other autoantibodies found include anti-keratin antibody, anti-perinuclear antibody, anti-filaggrin, and anti-SA antibody. All of these antibodies are directed against citrullinated protein, which are generated by modification of protein-bound arginine by the enzyme peptidylarginine deaminase. This enzyme is associated with granulocytes, monocytes, and macrophages, as well as other types of cells. Death of granulocytes and macrophages triggers production of citrullinated proteins, and overexpression of these antigens may provoke an immune response. Well, this family of antibodies is detected using cyclic citrullinated peptides, or CCP. Hence, the antibodies are called anti-CCP. Well, anti-CCP is now the lead marker for detection of RA because it is much more specific than RF. Now, in addition, low titer of anti-nuclear antibodies are present in about 40% of patients, and the pattern most identified is the speckled patterns directed against ribonucleoprotein. Now, the significance of this group of autoantibodies remains unclear because they do not appear to be directly related to pathogenesis. For the laboratory diagnosis of rheumatoid arthritis, well, it is made on the basis of combination of clinical manifestation, radiographic findings, and laboratory testing. There are two types of of agglutination, which use sheep red blood cells coated with IgG and latex particle coated with the same antigen. Testing for two other antibody classes of RF, we have IgG or IgA isotypes and IgM. Then the second generation anti-CCP EIA assay, which achieved sensitivity of 74% with a specificity of 96%, is used. C-reactive protein, or the CRP, ESR, and complement component, which used to follow progress of the disease, is one of the diagnoses for rheumatoid arthritis. Well, traditional therapy for rheumatoid arthritis has included anti-inflammatory drugs such as salicylates and ibuprofen to control local swelling and pain. The discovery that joint destruction occurs early on during the disease has prompted more aggressive treatment. We have the disease-modifying anti-rheumatic drugs, the DMARDs or DMARDs, such as methotrexate, hydroxychloroquine, sulfasalazine, lefonamide, and penicillin, are now prescribed if disease activity persists after 4 to 6 weeks of treatment with non-steroidal anti-inflammatory drugs. Corticosteroids such as prednisone cannot be used long-term because they are given in short oral courses for disease flare-ups. These agents appear to halt the inflammatory response and slow the progression of joint erosion. A recent development involves treatment with biological agents that block the activity of TNF-alpha. Agents that act against TNF-alpha are classified into two categories. First, the monoclonal antibody to TNF-alpha, which is infliximab and adalimumab, and second, the TNF-alpha receptors fused to an IgG molecules, the etanercept. All three specifically target and neutralize TNF-alpha, and they have shown very promising results in halting joint damage without producing major side effects. Now, any of these in combination with methotrexates are very effective in preventing radiological. A new agent, the rituximab, specifically targets the CD20 antigens and B cells, reducing the B cell population, prevents further antibody formation, and this has had a modifying effect on the disease. However, more research is needed to determine possible long-term side effects of rituximab. Thank you so much for listening, and I hope you learned something from this particular discussion. Thank you and have a good day.